Charles Hospital in Vancouver is closing its dedicated AIDS and HIV ward, and that's good news.
This is the history of the HIV epidemic in British Columbia. This is how it peaked, and I don't need to tell you where triple therapy became the norm, because triple therapy is exactly at the peak. And after that happened, you see that virtually AIDS disappeared.
I think it's fair to say that British Columbia is a leader in HIV care. We've been at the forefront of treatment and treatment monitoring for really since about the mid-90s, and in the past few years have been leading the world in expanding the HIV treatments so that we reduce the number of new infections in BC.
Richard has actually contributed in a unique way to our understanding of how to best monitor HIV disease at the clinical level. And many of the tools that he has brought to bear in the laboratory monitoring of HIV have contributed uniquely to our ability to optimize treatment for people infected with HIV in a way that we never anticipated it could be possible.
What our lab did actually as a whole over the past 15 years or so was to work together to come up with come up with tests so that people can select the best medicines for you. Done this in two ways. One is by looking at the virus itself that people are infected with, and one is also to look at the genetics of the person. So we're looking at both the host and the pathogen.
He has used human genetics to actually characterize the likelihood that somebody may have an intolerance to a given drug. So today we can use the viral genetics to choose the drugs that best fit your virus, and we can use your human genetics to decide what drugs may not be suitable for you.
We've been doing this type of testing for about 10 years now. It's just we've been expanding the number of tests that we do all the time. So this is HIV is unusual in that we've already been doing this personalized medicine for about a decade.
The ability of his laboratory to bring these new technologies and to facilitate the implementation in laboratories around the world has been of great success. And more recently, the ability that Richard showed on bringing interpretation tools, these are IT tools that are extremely sophisticated, that combine artificial intelligence and a number of other technologies to be able to take genomic information and to illustrate for clinicians, to interpret for clinicians what this all means. This is now readily available through his lab for access anywhere in the world.
For HIV, a large percentage of the number of HIV cases are in places where there's really resource-limited settings, so sub-Saharan Africa. The fact that we can share our treatments, share our testing methodologies is beneficial for the people there that really wouldn't have any way of accessing this methodology otherwise. But it's actually also incidentally beneficial for us, because if we reduce the amount of HIV in the world, there's going to be less in British Columbia as well.
I think most people are accustomed to hear about personalized medicine as something that is going to happen in the future, sometime down the road. Most people don't realize that actually Richard pioneered personalized medicine for HIV now for nearly 10 years.
For HIV treatment, I want to be around in the next several years where we first get rid of new HIV cases, new AIDS cases, new HIV cases, and finally HIV entirely from the province. I'm sure I'll be around for at least 2 or 3 of those.